Hi, this is Professor Grodman, and this is a review for Exam 2 in Psych 245. We are going to speak about some somatic disorders in Chapter 6. Let's start with somatic symptom disorder. There are one or more symptoms the person experiences without a full organic base, but there's concern regarding these symptoms, serious health concerns. With illness anxiety disorder, the concerns are more broad-based. This was formerly referred to as hypochondriasis or being a hypochondriac. Now it's referred to as illness anxiety, and there's a preoccupation with getting ill, and the symptoms are more vague. They're not, again, not specific to one or two things. Conversion disorder, another disorder under this heading, it has its roots back to Freud. He referred to this as conversion hysteria, where there are psychological conflicts which unconsciously get converted into physical symptoms. Serious symptoms, blindness, he actually called it hysterical blindness, numbness, and the first thing you need to do here is to get a medical eval, because these symptoms may be very real. There may be real organicity physically, so you have to rule that out first before even considering this diagnosis seriously. One more somatic disorder that is malingering, and that is deliberately feigning illness. You could hear a phone by me. Please try not to get distracted. This is a hard thing to do because there's always some distraction. Anyway, malingering, deliberately feigning illness to get out of responsibility. It is conscious. It is deliberate. And it becomes diagnostic when it becomes habitual, when someone does this all the time. Let's also go to the second part of that chapter and talk about dissociative disorders. The notion of dissociation is an emotional disconnect, a sort of sense of unreality, and there's a real continuum here in terms of the seriousness of disorders. Depersonalization is a sense of unreality, also referred to as derealization disorder. A detachment, but the person essentially sort of just takes a little mental vacation. They're in a bit of a fog state, but otherwise they're relatively high functioning. You just sort of disconnect and you sort of go into sort of almost a daydreaming state. It's particularly triggered by stressful, may not be a single event, but maybe a period of time. A single sort of response to a stressor like this is rather normal, and it's a normal adaptive functional thing intermittently. But if you start doing this in a more habitual way, it can get in the way of your maybe work or social functioning to some degree. Much more severe dissociative identity disorder is dissociative identity disorder, in which there is severe dissociation, a formation of separate identities. This gets a lot of play in media. This is typically in early childhood due to severe trauma, and becomes really a extreme coping mechanism to deal with this trauma. And ultimately, in terms of psychotherapy and psychotherapeutic intervention, it would be to try to combine or consolidate these separate identities. Okay, moving on to Chapter 7 in major depression. That is, that's the first diagnosis, but let's backtrack a second and talk about the notion of unipolar depression versus bipolar depression. Unipolar depression is depression of differing types, differing levels of severity and duration, whereas bipolar depression involves mania, usually with depression, but has to involve mania, extremes in energy, and can affect judgment and even result in psychotic symptomatology. Okay, what's major depressive disorder? Well, this is also referred to as major depression or clinical depression, where there are multiple depressive symptoms, oftentimes including suicidal thinking, but they include other symptoms such as hopelessness, helplessness, changes in eating habits and sleeping habits, and a lack of pleasure, ahedonia, that's referred to as. A sense of a lack of futuristic thinking, fatigue. These are, I think you need about 5 characteristics to meet the criteria for major depressive disorder. There is also, though, a duration component in terms of the criteria. Has to be at least 2 weeks. That's the minimum. There is no maximum. So someone could have this, unfortunately, for years. Typically, there are remissions. Sometimes people just have a one-time episode. Sometimes they have recurrent major depressions. But again, there's no mania here. A lesser but longer-term depression, usually not significantly impairing functioning, is referred to as persistent depressive disorder, sometimes called dysthymia or dysthymia, where there is a long-standing depression that a person may not even be aware of because there are only a couple of symptoms, and not suicide. So you might feel a little sad or irritable. That's probably it. Maybe I don't even think it's going to affect typically your eating or sleeping. So a couple of more benign symptoms of depression, and work and social functioning is largely retained. So this is a subtle one. Has to be present at least 1 year in children and adolescents, 2 year minimum in adults. There is no maximum for adults, and I guess neither for children, although they may age out of it. This is generally treated with cognitive therapy alone. Major depressive disorder mentioned before, typically treated with cognitive therapy plus antidepressant medication. Disruptive mood dysregulation disorder is really specific to kids who externalize a lot of anger, aggression, temper tantrums, irritability, but no mania. I think this diagnosis was developed in response to the growth of the designation of bipolar in children. And this is a distinction. There's no mania, so this child is acting out, is in pain, psychic pain, probably, but is not going through the mood swings of a bipolar, and certainly not the mania. So that ends our unipolar discussion, at least for now. Let's go into bipolar disorder, which again, there's mania and typically depression. And sort of the classic example of that is bipolar 1 disorder, in which the person experiences mania and then they go down to a very severe depression, really akin to a clinical depression, and that's bipolar 1. Some people do it more quickly. These are referred to as rapid cyclers, but there is this vacillation in mood that is much more extreme, much more than the average person. Bipolar 2, you have hypomania, increased energy, arousal, but not to the level of being psychotic or I think could be you have some thought disorder here, but it's not to the extreme of a full-blown manic episode. And although, unfortunately, the depression level here is severe. So there's hypomania and that vacillation to the depths of depression, or very, very severe depression. So there is a range here. Again, with, I don't know if I said this, but bipolar 1 would be treated probably with cognitive therapy and some sort of mood stabilizer for any of the bipolar disorders I'm going to talk about, which actually are 3, bipolar 1, bipolar 2, and something called cyclothymia, also referred to as cyclothymic disorder, in which there's not a full-blown manic episode, it's hypomania, and not quite the severe level of depression, hypodepression. But it's clinically significant and diagnostic. And again, meds here, mood stabilizers and cognitive therapy are also typically implemented and recommended. Suicide is often associated with depression, even more so with bipolar than unipolar depression. Suicide also connects to other diagnoses like major, significant personality disorders such as borderline schizophrenia, which is not a personality disorder, but yet obviously a very serious disorder. Certainly substance abuse like alcoholism. So often a substance abuse diagnosis along with a severe either personality disorder or other disorder, and usually depression, with some of the predictors of suicide. Suicidality in this country has increased in terms of completed suicides. Young people make more attempts than older people. Older people tend to complete suicide more. Part of the clinical interview or any interview with a person, any form of assessment, assesses suicidality. Is that person at risk? And if they're at risk, there's typically specificity in terms of plan and method. If there is specificity, I'm going to do it this way or that way, that's a concern. And you have a duty as a professional to make sure that person is safe. There's a duty to warn even the authorities, police, hospital, if need be, if that person won't go. I mean, someone's going to get involved in the case. You can't just let that person leave your door and leave your office unattended, unsupported. You try to do it as neutrally as possible with maybe a family member taking them to a hospital if they're at risk. But if there's any resistance or if that's not feasible, you may have to follow up with some other intervention like the police being called. But again, your job is to protect the person. Actually, this duty to warn supersedes your responsibility and your ethical responsibility, more specifically, in terms of supersedes confidentiality as sort of your priority as a practitioner. You need to make sure that person is safe. And if they're homicidal, you need to make sure for society. But suicide is probably more likely than homicide, particularly with regard to people seeking mental health treatment. Okay, moving into chapter 8, we talked about eating disorders and sleep disorders. Briefly, anorexia is characterized by anorexia nervosa, characterized by willful starvation, distorted body image. There is binging type, that's the more common. And then there are binging and purging anorectics, but their level of binging and purging is not to the degree of someone with bulimia. And their body weight is 15% or more, typically below ideal body weight. With bulimia nervosa, there is binging and purging and normal body weight typically. So there is a distinction there between them, although many of the dynamics with anorexia and bulimia overlap. Some of the family influences, some of the socio-cultural influences in terms of ideal body images being quite thin for women in industrialized Western culture, industrialized cultures. One more eating disorder to mention, binge eating, where there's binging but not purging. We had a brief discussion of sleep disorders, insomnia, difficulty going to sleep, hypersomnolence, excessive sleep, nightmares, more common in kids, associated with REM. You want to look at the antecedents, what is preceding these nightmares, and that's a sort of a psychotherapeutic intervention. If you do that, you look at the antecedents and try to address those. Sleep terrors are associated with non-REM sleep. They're also referred to as night terrors, and sleepwalking, non-REM sleep, more common in kids. Anything with sleep, especially the latter couple with sleep terrors and sleepwalking, you really want to get this person to a sleep study. I think that's true of anybody, just to rule out and determine what's going on medically. So that's, I think, an important strategy, an important step to take in terms of if sleep issues are the presenting problem. Typically, sleep issues are secondary to things like depression and anxiety, so they're not at least in mental health, in terms of mental health practice, not the primary presenting issue. But either way, not a bad idea to get them, and especially if it's primary, to a physician and a sleep study. Speaking of physicians and health and not mind-body connection, speaking of, but with regard to mind-body connection, is an area of psychology referred to as health psychology, the area of medicine referred to as behavioral medicine. And there are many theories here about mind-body, and certainly there is a relationship between them. One theory, of course, and this is actually research on this, that stress can affect health, particularly if it's chronic and severe. So where does stress come from? Well, stressors, things in your world. But it's not necessarily the objective stressor. High stressors, quantifiably are given high metrics. Things like losing a job, divorce, death of a loved one, health issues, moving. Many times people have these high scores, if there are scales to measure this, don't perceive a lot of stress. According to Arnold Lazarus at Rutgers University, I believe now either he's retired or no longer. Last I heard, he was still a retired professor and alive, but he is associated with a theory called cognitive appraisal theory. And this appraisal theory says that what makes something stressful is not necessarily the objective stressor, but how you appraise it. If you feel you can manage it, you have 4 exams and you feel, hey, that's not something terrible. I'm taking on that. I like that challenge. I love it. It gives me, makes me feel alive. Well, you're probably not going to feel very stressed. If you find that to be overwhelming, you're going to feel that, you're going to feel the impact of that psychophysiologically. So it's not necessarily the objective stressor, but the interpretation or the appraisal of the stressor. Another theory, separate from Lazarus, actually this is Selye, S-E-L-Y-E, regarding sort of this mind-body connection, is the general adaptation syndrome, GAS. It says if there is an event in your life, a stressor, in which an alarm goes off, you resist it. You have a tough day at work and you're ready to go out there and fight the good fight. Okay, that's pretty normal. But what happens if you do this every day, that this becomes part of your life and your behavioral repertoire, that alarm resistance model keeps on getting triggered. And eventually there's a third sequence to this, and that is exhaustion. Alarm, resistance, and eventual exhaustion. So that's Selye's general adaptation syndrome. We talked before about non-DSM terms which speak to mind-body connections. For example, type A people who are hard driving and ambitious, if they're overwhelmed by stress, these are the non-Hardys, they're more prone to heart disease. The type A Hardys who sort of go with the flow and take on a lot of stress but don't experience a lot of it, they're no more prone to heart disease. We had also referenced in our first exam, type Bs are very laid back. It's not really a predictor of health. Type Cs are super internalizers, particularly of negative emotions such as anger, and they actually are more prone to stomach cancer based on research. Stressors and health are influenced by certainly how we perceive them, i.e. the cognitive appraisal theory, but other influences, such as having a good social support system. The research is that people with better social supports live longer. People with good marriages also live longer, particularly men. Bad marriage is probably bad for your health. Serial marriagers who are married 3, 4, 5 times and divorced each of those times are more prone to health issues, including alcoholism and psychiatric issues such as depression. Psychotherapy and exercise share something in common. They're probably good at increasing serotonin and dopamine levels, but also they're good buffers for stress and tend to enhance mood. So there are many things that you can do to cope more effectively with stress, which are good for mind and body. Okay, let's move into chapter 10 that deals with sexual disorders and dysfunctions. The first term really is a little bit separate from that, gender dysphoria. This is where there is distress or dysphoria associated with conflict between one's biological gender and one's psychological identified gender. You are feeling distressed because your psyche, in terms of gender, doesn't match with your physiology. And this is not a disorder in the sense that because there is that discrepancy, but rather it's a disorder because you feel dissonance, you feel dysphoria associated with that issue, that physiological, psychological discrepancy. Many people who are transgender do very well. It's not a disorder, but when there is dysphoria associated with it, it is then diagnostic. Paraphilias or paraphilic disorders are quite a different matter. These are unusual sexual practices, often non-consensual. Some are consensual, but they're seen as really diversions or deviations from the norm, and some are actually criminal in nature. Some are not. So let's talk about some of these and the diversity of these, although there are some common threads as well. Transvestic disorder has to do with wearing clothing of the opposite gender, not for identity purposes, but for sexual titillation, stimulation, and gratification. These paraphilias also tend to be the primary source of sexual expression. So it's not that someone is experimenting once or twice, but it becomes a habitual pattern of behavior, and it is primary to them. Voyeuristic disorder, or voyeur, sexual voyeur, watching someone who does not know they're being watched and being stimulated and gratified by this. Exhibitionistic disorder, displaying yourself to an unsuspecting stranger by exposing yourself. These are more severe. These are severe disorders that connect often to power, control, need for power and control, issues with intimacy, and probably some experience that occurs in adolescence or childhood in which these behaviors are sort of are reinforced and then maintained because they're so rewarding psychophysiologically. There's the paraphilic disorders we're describing are predominantly male, with the exception of one, sexual sadism. This is the dominatrix. That sort of notion is someone who inflicts pain on another person, enjoys it, and that the receiver of that pain is a sexual masochist. And the masochist tends to be male, and the sadist female. And there's typically here a consensual relationship. So unlike voyeurism or exhibitionism, there is consensuality here. but it also can be very damaging in that someone is inflicting pain or even dangerous and the other person receives pain. But it is also ironic because the receiver of the pain, typically who is a male person, is in everyday life oftentimes a person of status who has a high-powered, high-control sort of position, and the sadist is often not in that position. So this is sort of a role reversal from their everyday life. Pedophilic disorder is maybe the most severe, probably psychologically the most severe of any of these. People who are pedophiles, who have involvements with children. The thing about this that also makes it a bit distinct from the others is that there's a learning history here almost every time. It's not something that just occurs because someone is titillated. Perpetrators of sexual abuse have almost always been victims themselves. They're, again, predominantly male, and they're not one size fits all. There are differences. There are people who are situational molesters who do it while stressed, and then there are preference molesters who have no involvement with adults. Clearly you can hear here some of the same issues with control, power, lack of intimacy, difficulties with intimacy. I mean, you're controlling someone who is not an equal based on age and where they are developmentally. So, and the impact of this is so devastating. People talk about this and feel tremendous shame. I've done some work with this population of folks, and I mean, everyone has this. If you're doing therapy or a clinician or a psychologist or clinical social worker, it's almost it becomes such a common thread among people who struggle that they have been abused sexually and certainly emotionally. They're tied together, many times physically as well. But this often creates tremendous shame in terms of sexual abuse. And therapy can help. I don't know if in terms of the perpetrator, there is some evidence that unless they really gain insight and have some motivation, there's really not a lot that's going to happen. And there's often not that. They act out because they don't connect to it. They don't see the connection between the person they're abusing and their own experiences. Let's switch gears a little bit and talk about sexual dysfunctions briefly. Sexual dysfunctions tend to have, in terms of etiology, in terms of cause, tend to be both physical and psychological. Male erectile disorder, difficulties achieving or maintaining an erection, has something to do with biological factors, age, health, medications, but also things like anxiety or depression, and/or hypoactive sexual desire disorder, lack of interest, very little libido. Again, having roots maybe in one's learning history, but also health, maybe relationship dynamics. Many things factor in, and as a clinician, you'd want to sort of get a sense of all the factors many of the factors on the equation that are contributing to these experiences. Female sexual arousal disorder, sort of the female equivalent of male erectile disorder, where there's a lack of physical responsiveness in a sexual interaction. And these are disorders that people will talk about. They will come into therapy for other reasons and recognize these. With regard to the aforementioned paraphilic disorders, those are sort of rare. The one that you will see, the paraphilic disorder that you'll see in clinical treatment, is pedophilic disorder, because people are often caught and required to go to treatment as part of a probationary condition. Sometimes with the others too, but much more so with pedophilic disorder. So we went through, and we'll go through very quickly, some the chapters 6 through 10. From somatic symptom disorder, one or more symptoms, with some health concerns specific to those symptoms. Illness, anxiety, preoccupation with getting ill, it's more general. Conversion disorder, unconscious. Psychological conflicts converted into physical symptoms. Don't make the diagnosis, though, until a medical eval has been done. Malingering, deliberately feigning illness to get out of responsibility. This is a habitual pattern of behavior. A few dissociative disorders, depersonalization, also referred to as derealization, sense of unreality, detachment. Usually not severe, but it can have some impact on functioning. And a much more severe one, which occurs typically or manifests typically in childhood, is dissociative identity disorder, in which there's severe trauma and children literally develop different identities. The goal of the practitioner, if you're working with probably, well, it could be a child, but more likely an adult or an adolescent, is to consolidate these identities. Chapter 7 deals with mood disorders, major depression. You have multiple depressive symptoms. The person's typically, I don't think I mentioned this, but their functioning level, both work, school, interpersonal, is affected, is pretty significantly affected. Therapy and meds are the, cognitive therapy and meds are the treatment of choice. Persistent depressive disorder or dysthymia, low-grade, long-term depression, cognitive therapy alone is typically recommended. Disruptive mood dysregulation disorder, a lot of acting out in children without mania. Bipolar 1 disorder, you have both mania and depression. Serious full-fledged mania and full-fledged depression. Bipolar 2, hypomania, major depression. Cyclothymia, hypomania, depression. With bipolar 1, 2, and cyclothymia, both cognitive therapy and medication therapies or medication therapy, i.e. A mood stabilizer would be the treatment of choice. Suicide has a connection to these disorders with depression. Suicide also connects to severe personality disorders and substance abuse and schizophrenia. Those are some of the common psychiatric classifications predictive of suicide. More completed suicides in the U.S. than decades ago. Young people make more attempts. Older people, more completed suicides. There's also an inverse relationship between suicide and homicide. One tends to be high, the other one low. We talked briefly about eating disorders, anorexia characterized by willful starvation, distorted body image, 15% or more below ideal body weight. And you have the restricting type, and you do have binging and purging here, but not to the degree of bulimia nervosa, where there's normal body weight and extreme binging and purging. Binge eating disorder, binging without purging. Sleep disorders, lack of sleep, insomnia, excessive sleep, hypersomnolence, nightmares with REM, and more so with kids. Sleep terrors and sleepwalking, non-REM. Sleep terrors, also referred to as night terrors. Health psychology and behavioral medicine both look at the mind-body connection. Cognitive appraisal theory of Lazarus looks at the importance of the appraisal, the cognitive part, in determining whether something is stressful or not. The general adaptation syndrome, CELI, looks at the 3-stage model of alarm, resistance, exhaustion. Type A's, separate from CELI, type A is a type of person who's ambitious, hard driving. There is the hardy type A who takes on a lot but does not get overwhelmed. Non-hardy does get overwhelmed, more prone to heart disease. Type B's are relaxed, not a predictor of health. Type C's internalizers, more prone to stomach cancer. Social supports, which are good, marriage, psychotherapy, and exercise, all help in reducing the ill effects of stress. Finally, in terms of Chapter 10, gender dysphoria, there is distress, dysphoria associated with conflict between biological and psychological gender. Paraphilias or paraphilic disorders include transvestic disorder, wearing clothing of another gender, not for identity, but for sexual gratification. Voyeuristic disorder, watching someone else who does not know they're being watched and getting sexual gratification. Flashing yourself to someone, exhibitionistic disorder. Inflicting pain upon someone, usually someone you're consensually involved with. The inflictor of the pain, the sadist, sexual sadism. The receiver of the pain, sexual masochism. Pedophilic disorder, obviously associated with pedophilia. Pedophiles have almost always been abused themselves. Those who abuse tend to be disconnected from it, their own abuse. You want to connect them, if you can, to that so they're more empathic and don't act out. Sexual dysfunctions, male erectile disorder, difficulty achieving or maintaining an erection. Hypoactive sexual arousal disorder, or desire disorder, has to do with a lack of interest, low libido. Female sexual arousal disorder, a lack of responsiveness to sexual interaction. And the etiologies of these sexual dysfunctions tend to be both biological, and the paraphilias for that matter, biological and psychological. Okay, hope you got something from this in preparation for exam 2. I will see you live, remote, online.